Thank you, Dr. Abdel Hayy, for your introduction. Actually, today, when I asked to prepare a talk regarding COVID and the heart, usually all of you is aware about the situation since the start of the epidemic and the cardiac presentation for those patients who was infected with COVID. You know, cardiologists are the first medical professionals that suffered from COVID, and the mortality among the cardiologists worldwide was high. At the presentation, initially, people was presented by symptoms related to ACS, symptoms related to acute heart failure, and so on. And at that time, the management was applied as pure cardiac disorder. Later on, when the mortality and the infectious rate started to be more and more among the cardiologists, the awareness and the interest is increased. I try to summarize because it is a big topic, lot of chapters, lot of clinical trials, everywhere, everyone is aware, public, medical, paramedics, everywhere. So just I try to make it short and to the point. So just first of all, what is coronavirus? Coronavirus, as all of you are aware, it is a causative agent of common cold. We have two previous recent outbreaks from this virus. The first one was SARS in 2002 to 2003 in Asia. Estimated around 8,000 people are infected, and the mortality is about 800. The second break, which is happening in Saudi Arabia in 2012 to 2019, and it's involved 27 countries. These estimated figures around 2,500 with mortality is also around 800. Then the latest version, which is the COVID-19 as a new strain. If we look to this diagram, it shows to us how the way of the infection is coming from the animals to the humans. And if we look to the first two breaks, we found that there's a pointer that we pointer. Okay, just if we are looking here, we found that intermediate host, either it's camel for MARS, or it is coming from the bat and the infected civettes in SARS, but still for COVID, they are blaming bats, but who is the intermediate host? As any other disease, there is a natural history of the disease. The natural history of the disease of COVID, we are suspecting initially when we are speaking for our colleagues for the infection disease and the infection control, what is the fate of this disease? This is that there is a cycle and there is an activation, plateau, remission, and the diseases disappear. But for COVID, there is something else. All the time we're still having time of activation, time of remission, and so on, in spite of the advancement and the advancement of the vaccination and the number of the doses. For all disease, we have either symptomatic or asymptomatic, and we have four outcomes. Either full recovery, or change to chronic infection, or having sequelae and disability resulting from complication, or finally ended by death. In December 19, the first case was diagnosed during the outbreak of viral pneumonia in China. And an initial epidemic has since rapidly expanded to global pandemic, affecting, at least at that time, 124 countries with significant morbidity and mortality. While concomitant and mitigation measures have been identified, and the disease-modifying pharmacological compound has been developed, the spread and the disease is still in distribution worldwide. Looking into this COVID, is this the first pandemic affecting the people in the earth? No, we have several. The history telling us that there is several pandemics. The first one starting, plague of Justinian, which is happened in 441 to 750, in which followed by deaths of 125 million. All of us also still remember the Spanish influenza that happened in 19th centuries, and also it kills a large number of people. Then, we are speaking previously regarding the two outbreaks that happened with SARS and MERS in 2003 and 2012. The genome was rapidly identified, and by January 30, this outbreak was declared and named by WHO as coronavirus 19. February 11, coronavirus study group of International Committee for Taxonomy and of Virus named the virus as SARS-CoV-2. On March 11, it is labeled as pandemic by WHO. As viral pneumonia, all of us suspecting that most of the symptoms is related to the respiratory tract. Why is this disease extended to other organs? It is a matter of the infection, or it is something else related to the autoimmune response, or whatever. So the clinical, the inflammatory consequence of the COVID are extending to the heart, kidney, and or liver as well. The cardiac involvement in COVID, there is a lot of effort try to identify what is the etiology. Why heart is affected in COVID infection? First, they are speaking about it is a response of inflammatory storm, the secondary to infection. Later on, direct invasion of the virus to the cardiomyocyte, because they found the as myocardial injury a result from oxidative stress, and also may be responsible for this one. Then, the worldwide survivor of COVID exceeding hundreds of millions, with some reporting complete or incomplete recovery, give a rise for a term of post-acute or chronic or long COVID syndrome. Persistence of symptoms remind that the need for vigorous cooperation between researcher and scientists to try to find a way for long-term management for such a problem. Management of cardiometabolic risk factors should become a priority for a physician, as both the pattern for the COVID and the cardiometabolic abnormalities are nearly the same. The long-term impact of the COVID on the cardiovascular health and the mortality, it represents now a major global concern. When we are looking to the evidence how SARS-CoV-2 affects the heart, there is two trusted sources. The first one, it is secondary to immune response. And COVID provoke a rule for release of cytokines, tumor necrotizing protein P, and a lot of others that accelerate the process of inflammation and the damage to the myocardium. Secondly, which is also an interesting point, is that the cardiac tissue damage, because of the distinct spike protein of the virus that directly attached to angiotensin receptor in the heart. And as this attachment and this allocation between the virus, the protein spike of the virus and the receptor facilitate the transfusion of the virus particle to the myocyte and start the process of inflammation and the sequelae that happen later on. This evidence by what? In post-mortem heart examination, there is an evidence of microvascular thrombi and cell necrosis. And the area of muscle death happens in 35% of the autopsy for the trusted sources of the examined people. Also, they found that there is a blood clot in the capillaries, in the small blood vessels in the heart tissue. Look to this diagram, please, and we can look here to how the virus affecting the heart. Either through direct effect or indirect effect, we have direct cardiac toxicity, We have dysregulation of renin-angiotensin-aldosterone system. We have endothelial damage and thromboinflammation. We have demand-supply mismatch. And all of these things, all of these pathophysiological mechanisms will result in acute cardiac injury. And the term of acute cardiac injury in COVID, it is related to the raised troponin and the raised cardiac biomarkers. This can lead to acute coronary syndrome, AMI, myocarditis. And as a result of this injury and the insult to the heart can lead to rise for arrhythmia, heart failure, and shock. Plus the hypercoagulable state that result in venous thromboembolism and pulmonary embolism. When we are looking here to the motive mechanism to explain how COVID put forward decide for the affecting the heart and the cardiac patient. Look to the first one, systemic inflammatory response, secondary to cytokine storm, immune deregulation, and inflamed plaque. And as all of you is aware, atherosclerotic plaque in the coronaries, if it is inflamed, it started to have fissure, and then flap dissection, and started the process of atherothrombosis with the acute coronary syndrome manifestation. Second thing, when you are looking to oxygen demand supply mismatch, we are using the extracardiac reserve. We are exhausting our heart. It result from hypoxemia, increased myocardial oxygen demand. The third point was the angiotensin converting enzyme receptors and the direct invasion of the virus particle to the myocardium. Then finally, the cardiac microvascular injury. This slide summarizes the cardiac injury mechanism during COVID. And we can look to these four main components, either dysregulation and overwhelm from the inflammatory process, the mimic the attachment of the virus to the receptors, and the supply-demand mismatch. If we are looking to the acute manifestation of the COVID on the heart, cardiac patient, non-cardiac patient, what is the presentation, what is the problem? We have myocarditis. And all of you is aware about the myocarditis now, post-COVID, post-vaccination, a lot of debates, a lot of speeches coming and the report, clinical trials speaking about incidence, how we can predict and how we can treat. ACS, either type 1 or type 2 MI. Type 1, it is classic, atherothrombotic. Type 2, it is demand-supply mismatch, non-ST elevation, and unstable. Then we are speaking about arrhythmic complication, all types of arrhythmia. We are speaking about heart failure with reduced ejection fraction or with preserved ejection fraction, cardiogenic shock, stress-induced cardiomyopathy, acute pericarditis, pericardial effusion, tamponade. So if we look to all these cardiac, we have all layers of the heart is affected. And the interaction between the COVID and the ACE angiotensin converting enzyme receptors, it causes a change in the pathway. And as all of you is aware, this receptor in the lung, in the heart, and in the endothelial cells. And this explains the widespread effect of COVID in the cardiovascular and the rest of the system. The prevalence of acute cardiac injury among the COVID patients are ranged between 10 to 23%, with higher frequency in the intensive care patient, 22 versus 2%. And those patients that he have higher rate of cardiac injury, it showed also respiratory finding in the lung by mottling and the ground glass appearance. If we are speaking about acute cardiac injury, ACS, it started from where? Plaque rupture, coronary thrombosis, and the effect of the medication used during the treatment. There is a lot of empirical medication were used. corticosteroid was used, antifungal, immunological agent, cardiotoxic. All of these medication having side effect on the heart, and it results in acute myocardial injury, either plaque, instability, and dissection, or coronary vasospasm, or increase the thromboembolic complication. Increased cardiac metabolic demand secondary to infection. And the other thing is the hypercoagulable state, endothelial dysfunction, and the hypoxemia as a result of pulmonology involvement and the fibrosis. When we look to the myocardial injury, it has a reflection on the outcome for the COVID patient? Yes. When we are looking to the in-hospital mortality, it was 60% with a myocardial injury patient versus 8% in patients who have normal troponin level. And you can imagine the big difference here, 60 to 8. Another thing, when we are looking to sub-analysis of this result, the mortality is 8% in patient who has COVID without underlying cardiovascular disease and the normal troponin. This 8% increased to 13% if there is underlying cardiovascular disease but normal troponin. But look, please, when the troponin started to increase, it is 38% without underlying cardiovascular, and it reached 69. So it is, if you compare from here, from 8 to 69, you can imagine the number of the mortality, and it's a close relation to the cardiac patient. And this is why when we have patients have cardiovascular disorder and they got infected, it is a critical, and we should give him care because the mortality is high, especially if we found that raised the troponin for them. Second common problems from the cardiac point of view in a patient with COVID is heart failure. And as all of us is aware, heart failure can happen post-pneumonia in general, either secondary to the stress of the infection, hypoxemia, increase the metabolic, required demand-supply mismatch, and. But here in COVID, we have a specific reason. So, is this one is related to the new onset cardiomyopathy that developed during COVID, or it is developed due to right side heart failure, second to pulmonary hypertension? Those patients in COVID having extra pathophysiology and the pathological response, pathological pathways responsible for heart failure over the other normal pneumonia patient. When we are looking to right ventricular hypokinesia, it was observed in 66% of COVID patients with right ventricular enlargement versus 5% only.
1 minute for summary and conclusion.
Okay. Versus 5% only in COVID-19 patient. For sake of time, I'm going rapidly just here. To look for this one. What is the long COVID presentation? As all of you is aware, the long COVID presentation is either chest pain, and we are facing a lot of patients coming in post-COVID having chest pain, having palpitation, having postural hypotension. I am going here to concentrate on this point, which is called, when we are looking to the this one, postural orthostatic tachycardia syndrome, and the symptom of this autonomia. Please look to this term, POTS. This represents a major number of patients that represented to us now. Pain, chest pain, palpitation, and hypotension with dizziness. This is called postural orthostatic tachycardia syndrome and the symptoms of dysautonomia. This one is first is treated if by liberal fluid intake to maintain the blood pressure during changing position, and if the blood pressure is allowing, especially with palpitation, we are going to give beta blocker If it's not responding, we are also move to the exercise program that encouraging maintain the blood pressure with the change in the position. If the symptoms is persist, we are going to give medication like corticosteroid, like midodrine, and other medication. In the end, we can summarize, and speaking about COVID and the heart, it is the major issue. Cardiovascular system is the big system in spite of it is viral pneumonia, but it is the major system affected, reflecting mortality. The management for cardiac disorder in COVID, it is similar to non-COVID condition by the guidelines. But the interesting point, just I wanted to share with you that the number of the BCIs and the patient presented with acute coronary syndrome ST segment to the hospital was decreased during COVID, and the explanation was two things. First, it is the fear of the patient to go to the hospital and contact with the sick patient. Second thing is that most of the hospital was flooded with COVID patient and they are shifted the surface. The last thing here is related to one thing, which is effort is required by multi-center, multi-ethnic, randomized controlled trials to identify the proper protocol of management of COVID, especially for cardiovascular patients. Thank you so much.